Welcome everyone to today's Bitesize session. This is a joint Bitesize session for October Rett Syndrome Awareness Month, which we're holding in collaboration with Rett UK. And I'd like to thank Julie Benson and Rob and Beth, my colleague Beth Johnson, for being here today to present this session. So before we formally introduce our presenter today, Beth and Julie, would you like to just briefly introduce yourself, starting with you, Julie?
Okay, thank you. Hi, I'm Julie Benson. I'm the Family Support Manager at Rett UK.
Hi, I'm Beth. I'm Events and Outreach Lead at Reverse Rett.
And I guess I should introduce myself as well. I'm Rachel Stevenson, and I'm CEO of Reverse Rett. Okay, so I should say as well that the Reverse Rett Bitesize sessions are funded by the Pears Foundation, and we are grateful for that ongoing support. The session will be recorded, so if you want to have your camera off, go ahead, but please flick it on in the beginning so that we can see that everyone here is a person. The chat box is open for questions, or you can ask in the traditional way, just put your hand up or put your virtual hand up. But please do keep yourself muted until you're speaking so that the sound quality is good. So on to today's session, we are being joined by Dr. Ruksana Ahmed, who is consultant clinical psychologist at the SIP Rett Centre and at CIPPRD, which is the Centre for Interventional Pediatric Pharmacology and Rare Diseases, which is a national specialist CAMS provision based at the Maudsley Hospital in London. And I think, Ruksana, you've worked there for many years, haven't you, in partnership with Professor Santosh and team. And I should also add, and I'm pleased to be able to add that Ruksana has also recently joined the Board of Trustees of Reverse Rett. And we're really delighted to have her here today to speak to us about anxiety and Rett syndrome. So Ruksana, thank you so much for being here today. And I'll now hand over to you.
Thank you very much, and thank you very much for the kind introduction, and always from my point of view it's just a real pleasure to be invited and have this opportunity to spend some time with you all. So I'm just going to attempt to share my screen. I think, Rachel, just to add to your comment as well, I'm happy to take questions, but I think once I share my screen, I may not be able to see the hand raise consistency. So just if I could get some support with that, that would be great. So I'll just do that now.
You may need permission, I think. Oh no, you've got it. Great.
And are people able to see that clearly enough? Okay, that's brilliant. Okay, so Rachel, like you've already highlighted, in terms of the session today, just an opportunity to think more about anxiety and anxiety generally as well, but then obviously more specifically in terms of how it can present in the context of Rett syndrome, but also to think about together in terms of what are the opportunities for us to sort of support both people with Rett syndrome experiencing these symptoms, but also in terms of sort of parents, carers and families as well. In terms of what I wanted to try and cover today, just really sort of just to place things in context a little bit and think about sort of emotions generally, including anxiety. Also in terms of from a context point of view, just to think about anxiety and emotional psychological difficulties generally, but also then prevalence and presentation in children, young people, adults with learning difficulties, neurodevelopmental disorders, and then obviously rare diseases, specifically Rett syndrome. Then really to sort of share with you together, and I'm sure it's things that you're already aware of, but just really sort of what are the signs and symptoms of anxiety and other disorders as well. But actually also then how some things, what we might need to hold in mind in terms of how some of these symptoms can present slightly differently in our people with Rett syndrome and other disorders as well. And then also specifically just link that back to the work that we've done in the centre, and specifically around EBAD, and how that links, and then thinking about sort of interventions. I will briefly mention sort of pharmacological sort of our interventions, our model within the centre, but obviously that wouldn't sit under my expertise in terms of as a psychologist. But obviously, because it's quite an integrated, holistic model, I will briefly mention that, and then also think more about sort of non-pharmacological interventions and options that can be considered. And then just very briefly to bring that back to sort of parents, carers and families, and perhaps think together about system-wide implications as well. And absolutely sort of throughout and at the end, more than happy to take questions or sort of really encourage as much discussion as possible as well. So in terms of just generally, I obviously this, I'm really clear this is stating the obvious, but I think it's really important, all of us, including sort of our family members with Rett syndrome, but all of us, we will experience a whole range of sort of emotions and feelings. And obviously that will be a combination of both positive and negative emotions and feelings as well. And, we're focusing on anxiety and low mood today. But the other aspect for me is that actually, these feelings and experiences are in the context of our young people and people with Rett syndrome also demonstrating significant resilience, significant strengths and abilities as well, and both within themselves and within their families around them. Huge protective factors as well. So for me, it's always very, very important that it's not assumed that we're just sort of focusing on the negative, but also sort of the resilience, strength and protective factors are very, very important in terms of contributing to positive progress and outcomes, of course, as well. Just briefly, again, just thinking about positive and negative emotions as well. Again, we'll focus on more the negative today, anxiety, low mood, etc. But again, something that we miss definitely as professionals. So I always flag it when I'm sort of doing sessions like this or training colleagues as well, is that what we forget sometimes is that positive emotions impact on people with Rett syndrome and all of us as well. And obviously it's not that we don't want sort of positive experiences, that's exactly what we're aiming for, but it's just really helpful to keep that in our sort of overall thinking somewhere as well, that actually those positive experiences and emotions as well can sometimes present as anxiety or increase anxiety in people with Rett syndrome and other conditions as well. Now, in terms of, before we focus more on anxiety, I think what's really, really important in Rett syndrome, what's really important is that we're really aware that actually there's still so much stigma and difficulty for us all in terms of thinking about sort of mental health difficulties and emotional difficulties. And I suppose the purpose of this slide is even before we think of our family members with Rett syndrome, the reality is that common mental health disorders such as anxiety, depression, phobias, OCD, panic, etc. The reality is that they're very, very common, both in children and adolescents and adults and in the general population as well. In terms of thinking about sort of children generally and adolescents generally, COVID has contributed to this as well, but even prior to COVID, we were thinking that at least 1 in 8 children and young people between 5 to 19 are likely to be experiencing a mental health disorder. And the reality is that those numbers have shifted and the needs have increased further, and we feel that it's closer to 1 in 6 now. And then equally for us as adults together, the reality is that it's very, very common in our lifespan that there's a very high chance that we will potentially experience these difficulties ourselves as well. So currently in terms of prevalence rates, it stands at approximately 1 in 4 adults are likely to have a mental health disorder that will require support and intervention. Then when we begin to think about children and young people and adults with a range of disabilities and difficulties, the reality is that then those prevalence rates increase quite significantly. So we predict, and the research and evidence indicates at least a 4-fold increase in the likelihood of children, young people and adults with disabilities experiencing mental health conditions as well. In terms of evidence relating to rare diseases and rare diseases more generally, again, there's a significantly higher risk of experiencing mental health difficulties as well, alongside the rare disease. And specifically in some of the research that's been done where whether it's sort of children, adolescents or adults with rare conditions are able to report, what the reports indicate is that there are high rates of both low mood and depression, symptoms of those, and actually even higher rates of anxiety that are reported. So I suppose really the overall message is that actually it's likely and probably more common than perhaps we realise that children, adolescents and adults with Rett syndrome are likely to experience symptoms of anxiety disorders, low mood, depression, and also we'll think specifically about emotional and behavioural and autonomic dysregulation as well. The other area where we have research around rare diseases as well is that both parents and carers and family members of people with rare diseases do also then report high levels of anxiety and low mood symptoms at times as well. And again, as we know when we've spoken often, there's very, very clear reasons for that in relation to the sort of the family experience of having a family member with Rett syndrome and support that's required. In terms of just sort of generally as well, when we're thinking about sort of, I touched on the stigma around sort of thinking about mental health difficulties, mental health disorder. I suppose what's really important as well is that this isn't about sort of pathologizing in terms of these difficulties at all. And actually these are all very, very normal emotions that we experience on a daily basis, you know, at any point in time. I suppose what's quite important is that, you know, knowledge is power. So in terms of sort of knowing about these symptoms, but knowing about what point we might need to become more concerned about symptoms and difficulties that can arise. So in some ways, the way that we view this is that it's really important that we think the monitoring. I mean, we're talking about health tracker, but it's really relevant, and all monitoring systems in terms of thinking about both the severity of symptoms, but also the crucial sort of bit as well is that also then how much additional impairment do those symptoms generate as well. And the other reason I just wanted to sort of throw this slide up as well is that what we know from children, adolescents, adults with neurodevelopmental disorders, other difficulties as well, is that there is some general consensus and understanding that actually the baseline anxiety levels are slightly higher anyway. That doesn't necessarily equate to impairment, but I think it's very, very interesting for us how we think about young people, family members with Rett syndrome, that actually before demands are placed, that potentially sort of baseline anxiety levels can be potentially higher anyway. Now, in terms of sort of, before thinking about sort of specific symptoms, this I'm sure everyone is aware of, but I think it's quite helpful sometimes just to sort of think together again that what can be sort of some of the typical triggers for emotional difficulties such as anxiety in Rett syndrome and more generally as well. And I suppose the way sometimes to help about think about it helpfully is to think about external and internal triggers. In terms of external triggers, there's things that we're very familiar with in terms of planned or unplanned changes to routine and transitions. Another one that sometimes, again, professionals can miss sometimes is almost a lack of stimulation in terms of what is being offered and available to our family members with Rett syndrome from an external point of view. We've mentioned changes of routine. Sensory triggers are very, very important. And again, in the context of communication difficulties, it can be sometimes more difficult to evaluate, but actually it's very, very important that these factors are included because they can have quite significant impact on emotional well-being in our family members with Rett syndrome. Other things from an external point of view, when there are changes, whether that's within the home environment, outside of home environment, sort of familiar people, family members, changes to staff and carers, etc. These relationships are very, very important to our family members with Rett syndrome. And obviously, by definition, what can potentially then have quite significant implications if changes, planned or unplanned, arise. The other thing to mention as well is that seasonal changes are quite important as well. And again, we're sort of more familiar with this in the general population in terms of how we sort of maybe all dip a little in the winter or the colder months. But we're very familiar with seeing these sorts of variations in our family members with Rett syndrome and other disorders as well, particularly in the context of low mood, symptoms of low mood. But again, these are all sort of external factors that it can be quite helpful to think about and include in our thinking. And particularly what's interesting is often the external and environmental factors are things that we can implement some quite helpful strategies around as well. In terms of internal triggers, obviously sort of acute physical illness can exacerbate, as we would expect, any sort of underlying symptoms of anxiety and or low mood or distress. Puberty is probably the most obvious developmental stage, but obviously all developmental stages of transition, but puberty specifically in terms of the significance of the physiological changes that can arise from an internal point of view. Medications is quite interesting, and obviously our, Professor Santosh, our services expertise is around specific medications, but also Professor Santosh's expertise around psychopharmacology. But I suppose I just put that in there as well, is that we sometimes, again, for me, this relates back a little bit to the sort of stigma around mental health and then potentially treatments for. But actually all medications can potentially have positive impact and consequences, but there can be side effects associated, and often medications for physical aspects of need as well can have side effects that result in changes to behavioural presentation as well. So often the most common ones around things like that are, for example, anti-epileptics. Can contribute from that point of view as well. Obviously, we know in Rett syndrome, it's multi-system, systemic, and in terms of the internal physiological changes. And I suppose for me, it's sort of, on every level in terms of sort of all sort of bodily functioning and systems, but we know a lot of our family members with Rett syndrome will have complex gastrointestinal sort of issues and needs as well. But if any system can potentially be impacted, then what we have to also be aware of, and this isn't that our families aren't aware of it, but us as professionals as well, is that subtle and more significant changes are continuing and dynamic. So these will absolutely contribute to, you know, how a family member with Rett syndrome is feeling as well. And of course, I suppose that from an internal point of view, the co-occurring physical conditions. So I touched on epilepsy, but that's just one of many in terms of physical diagnosis, co-occurring conditions that can also contribute to the physical and emotional experience for our family members with Rett syndrome as well. Now, in terms of any questions so far? Is the pace okay? Am I don't, brilliant, thank you. Thank you. Now, in terms of just sort of focusing in a little bit more on anxiety, what I wanted to do was sort of just share with you, and again, this is things that we'll all be directly and indirectly familiar with, just what we know about general signs and symptoms of anxiety, because these are sort of generic, which means that having Rett syndrome doesn't necessarily mean that these won't be similar, but the presentation and or sort of symptoms can vary. But usually it's quite helpful to cluster signs and symptoms in sort of 3 groups. I've started with cognitive symptoms. So really in terms of what's happening from a thinking, thought point of view and cognitive point of view. And I suppose what I would say is that then this will vary depending upon cognitive abilities. But the reality is that these difficulties, some version can still be very present in anxiety. So difficulty concentrating, anticipating or fearing the worst outcomes, the mind going blank, uncontrollable and obsessive thoughts, thoughts and feelings, fears of sort of going crazy. It's not sort of a word that sort of, from my point of view, there's never any judgment around terminology, but this is often how we can sometimes, it's the only word we sort of can grasp or use sometimes to describe it. So often young people and sort of adults will use this term. Experiencing anxious thoughts and or images. So this is something that's quite interesting as well, depending upon sort of levels of functioning and profiles, is that it's not always sort of clear thought structures, as it were, but actually visual images can arise, sort of very fearful images as well. Obviously automatic anxious thoughts. And in terms of this anxiety, this impending sense of danger or that something bad is going to happen. So that's sort of roughly sort of, and again, not all, but sort of the main sort of cognitive symptoms that can arise. Then in terms of behavioral symptoms, restlessness, agitation, inability to sort of rest or be at comfort, sit still, remain calm, social withdrawal, also almost not feeling safe or able to leave the sort of safest environment, as it were, and that's often home. Difficulties completing tasks, meeting demands and expectations, whether that's school, work, etc. Irritability, exaggerated startle reflex. And that's quite interesting, is that you can see that in all levels of functioning when anxiety can be present as well. In terms of the other area of symptoms, which is really important, and I wanted to flag this in this way because this is even before we think of our family members with Rett syndrome, who are actually very, very physically compromised in terms of, you know, central nervous system, etc., and multi-system organically areas as well. But generally, in terms of physical symptoms and signs of anxiety, can include shortness of breath, can include fatigue and exhaustion, can include insomnia, changes to eating and sleeping, sweating, gastrointestinal symptoms, muscle tension and pain, pounding heart and changes to heart rate, fine muscle tremors and shakes, headaches, numbness and tingling, pins and needles, and often dry mouth as well. And again, you know, from a physical point of view, not sort of an exclusive list, as it were, but this can be very, very common in anxiety generally as well. What I wanted to just sort of add on is that even though the focus is on anxiety, the reality is that we also know that low mood and depression is very common. And also what we know from our work with children, young people and adults with ASD, LD, and rare diseases as well, is that often it can be a mixed presentation or co-occurring presentation of anxiety symptoms and symptoms of low mood. And there can be overlap as well. So I thought it might just be helpful just to highlight some of these symptoms as well. And again, in a similar fashion, thinking about cognitive symptoms first. So it can be negative thoughts about oneself, the others, and the world around us. It can be negative automatic thoughts and ruminations. Feelings of worthlessness and hopelessness. Unfortunately, there can be very, very negative thoughts and visualizations around death and or suicidal thoughts. Again, difficulties thinking, concentrating, difficulties making decisions, and memory difficulties can be very, very common as well in the context of sadness and low mood, and lack of motivation. Again, from a behavioural symptoms point of view, that you'll see that there is overlap, but there are some differences as well. Increased sort of tearfulness and sometimes sort of episodes of crying and distress without identifiable causes necessarily. Irritability is a very interesting one in children and young people of all levels of functioning, and in the context of Rett and rare diseases as well. Irritability is often a symptom that can present, often more so sometimes than episodes of tearfulness in the context of low mood. Restlessness, aggression, self-harm and self-injury, a lack of energy, and also when we've seen quite extreme sort of experiences for people, including children and adolescents as well, slowed speech and body movements as well. Again, then just thinking about sort of biological and physical symptoms as well. Again, there is overlap clearly with anxiety as well, but changes in appetite and eating. And again, with all of these sort of symptoms, it's changes from baseline. That's quite important. That's where we're very, very careful to individualize and tailor our assessments. But the reality is actually, even with all of our work, often, and this includes professionals, often symptoms of depression and anxiety are actually missed. So rather than sort of overdiagnosis, the reality is that these symptoms often are missed. So just from a biological point of view, changes to sleep from baseline. And with these biological aspects, it can be both decreases and increases in both eating, appetite, and or sleep as well. Increase in experience of physical symptoms and pain, and also unexplained physical difficulties, headaches, body pain, etc. And I suppose just before I move on to this sort of, you know, what does this then, so if that's what we know about sort of how symptoms can present, what do we need to think about in terms of then thinking about sort of these experiences for our family members with Rett syndrome? And what do we know from other conditions and disorders and work that we've done already? And I suppose the reality is that there is going to be a significant impact in terms of the communication difficulties that can often be present in the context of Rett syndrome. The other aspect as well is that, you know, often our family members will communicate through their behavior. And the reality is that what's very, very important is that changes in behavior aren't construed as intentional necessarily, or attention seeking. I'm sure that all of you as parents and family members will have had experiences where either these thoughts come to mind, or these things are being suggested by sort of multi-agency professionals, etc. I suppose what I'm not saying is that our family members will bring their personality, their tenacity, their smarts to all of their sort of environments and relationships. So it doesn't mean that they won't sort of want to do things a certain way and all of those sorts of things. But the reason I'm just highlighting this is that the reality is that we unfortunately hear too often that very, very real symptoms of anxiety and or low mood and other mental health symptoms are often sort of misconstrued as someone being difficult. I struggle to say it because it's so counterintuitive for me in terms of how we work, but the reality is it can be common. And also within this area, in terms of sort of how we think about terms like challenging behavior, behaviors that challenge, etc. The bottom line for me is that in the context of our family members with Rett syndrome who have a range of communication strengths and difficulties, the reality is that often they and we communicate through our behavior. So it's very, very important, both in terms of sort of empowering our families, but also as professionals in terms of from a training and expertise point of view, across disciplines to understand behavior in the most helpful way as possible. The other aspect that's very, very important is that our family members with Rett syndrome and a range of other conditions as well are highly likely to displace symptoms across contexts. So the most obvious example of this that you may have experienced over the years is that people will say, well, she's absolutely fine at school. We've got no worries at all. She's absolutely fine. We don't understand, what do you mean that this is happening at home, or what do you mean that you're worried about this? But the reality is that actually the nature of Rett syndrome and a range of disorders and difficulties is that there can be both an accumulation of symptoms, and there can then most definitely be a displacement of symptoms across contexts. So just because symptoms of anxiety are not as obviously presenting within one context, or more obviously presenting in another context, does not mean that person with Rett syndrome isn't experiencing anxiety. Equally, it doesn't mean that parents are over-reporting or misreporting. And again, I'm just sort of throwing out sort of things that sort of families share with us in terms of their experiences when they're sort of seeking help or wanting to access support around some of these things. The other very, very significant issue is that the external presentation may not always be completely congruent with the internal emotional and physiological experiences. And this is very, very common in Rett syndrome, but actually it's very, very common across a range of different disorders, neurodevelopmental disorders, learning disabilities, rare diseases. And for example, I'll have colleagues who will phone me up and say, but every time I see her in clinic, she's smiling. And I'm like, yes, that's brilliant. We want the smiles to keep coming, but that doesn't necessarily mean that there isn't symptoms of anxiety, there aren't symptoms of low mood. Again, doesn't always necessarily need to be severe or impairing, but sometimes it really can be. So that's something that I think is very, very important, that actually, and that's where for us over the development of our service and the centre, the inclusion, we have a lot of clinical expertise in terms of, as clinicians, in terms of collecting observational data, completing very specialized functional analysis, using our standardized measures and questionnaires that have all been modified for specific sort of groups of conditions like Rett syndrome, as you're familiar with, but also collecting physiological data. Because actually, if externally there's no obvious representation of physiological changes, which can be very common, then we do need to try and access that information. And that's where the work in our centre, particularly around the biophysiological sort of devices, and incorporating that data into both our highly specialist assessments and then intervention and recommendations as well. In terms of misattribution, what do I mean by that? So I suppose the challenge really is, I'm sure we would never want, you know, obviously we always say that physical health difficulties and Rett syndrome and the core condition always sort of trumps sort of our assessment, our evaluation, our interventions. But what can happen sometimes is that because there's a less of an understanding about the emotional psychological consequences, both cognitively and physically in our family members with Rett syndrome, often things like anxiety, things like these other areas aren't necessarily in our professional colleagues' frame of reference, and that can be common across agencies as well. So I suppose there's something about, you know, we always say we call ourselves in our service splitters. That doesn't mean that we all sort of as a team fight with each other or fight with other people. But what it is that we don't lump everything under a core condition, for example. So obviously we know the implications of Rett syndrome and other conditions. But the reality is, in most of these rare diseases, there can be numerous co-occurring conditions. But I suppose the issues that can include physical health difficulties, but what can get missed is the emotional and behavioural and mental health difficulties as well. Now, I think that slide possibly is in the wrong place. No, it's in the right place, I apologise. So in terms of then thinking about sort of more specifically Rett syndrome and sort of pulling all of these different aspects together, and in terms of the work that the centre is doing and has been doing for some time, in terms of thinking about, you'll have heard the term emotional behavioural autonomic dysregulation. Now, the reality is that we're doing a lot of work with this in Rett syndrome specifically, but the reality is that there's sort of been a lot of work going on in a number of different areas. And I suppose at its inception, for our team particularly, it speaks to sort of when we started our work, sort of like Rachel, you were saying, many, many years ago. But what we were seeing in our young people was these almost sort of, even in our young people we were working with without rare conditions, were these extreme physiological reactions in the context of anxiety and their day-to-day difficulties. And the other areas where we started thinking about this is our work in acquired brain injury. And then obviously in all of the rare disorders that we've been working with for many years and Rett syndrome. So this is a construct that actually what we feel is that this is very much can be present often in Rett syndrome. And often, you know, it sort of makes sense because if Rett syndrome is a condition that impacts so significantly biologically, a range of systems, the reality is that the presence of autonomic dysregulation is likely to be very, very high. But also what we see is that autonomic dysregulation is also very common in autism, can also arise in a range of other emotional behavioral presentations as well. So in terms of autonomic dysregulation, what that refers to is sort of, and specifically in Rett, in terms of that, the term is unrestrained vagal tone, but what that refers to is sort of the significant difficulties that can arise in both control and regulation of breathing difficulties, temperature abnormalities, vasodilation, vasoconstriction, cardiac problems, gastrointestinal problems as well, flushing, sweating, etc. And again, it's very interesting is that a lot of those things overlap with what we were saying about our general understanding of symptoms and of anxiety anyway as well. Then thinking about emotional dysregulation. So we've talked about anxiety, but obviously phobias can arise, panic attacks, mood dysregulation can arise, low mood like I've discussed, loss of interest, and then also hypersensitivity. So in terms of all of our family members with Rett syndrome will have their own individual sensory profile, but obviously that can then be impacted both from a physical point of view, but also from an emotional dysregulation point of view as well. And then thinking about behavioral dysregulation. Again, some of these things I've covered already, but again, under this sort of construct of EBAD, thinking about screaming, thinking about self-injury, self-stimulation, rocking, stimming, stereotypies, scratching, agitation, sleep problems. So again, what I wanted to do was that obviously, I think a lot of the group will be aware of this construct and how we're thinking about it specifically in Rett syndrome, which is very specific. But it's sort of almost a culmination of pulling together a sort of our developing understanding and work around both Rett syndrome and rare diseases, but also the interface between sort of physical health, significant physical health difficulties in Rett syndrome, but also how that impacts emotion and behavior as well. So if we have identified all of these things, what are the routes and avenues to access support, and what can we do to help from an interventions point of view? And I suppose, again, just to start with some key messages again from my point of view, the reality is that not the majority, all mental health disorders in children and adults are treatable. So I think for me, that's the really starting point, obviously in Rett syndrome, but actually generally, these are things that we can really do something about. And also when the treatment, once the symptoms have been identified, the reality is that actually it can lead to quite significant improvements, both from a symptom reduction point of view, but then in the context of symptom reduction, how those things can directly and indirectly impact all other areas of life as well. For example, we have a lot of young people who the anxiety is interfering with them accessing other therapies that we know that actually will potentially contribute very positively to their continuing, maintenance of skills, different areas of their physical health functioning, etc. And then obviously the most significant thing that we always hold in mind as a service for all of our family members with Rett syndrome and all of our families is just really the potential for impact on quality of life. If we are able to achieve some improvement in these symptoms and areas as well. There are evidence-based treatments, but actually the treatments require quite significant modifications, and that applies to both pharmacological and non-pharmacological interventions as well. And anyone who sort of knows us or has had any contact with us will know is that right from inception, not just in sort of the Rett Centre, but our sort of clinical model has always been highly personalised and tailored. So for us, it's sort of, even if a family member has a diagnosis of Rett syndrome and anxiety, or Rett syndrome and epilepsy and anxiety, that doesn't mean that those two individuals necessarily are going to be completely the same, and we should never assume that, and equally most definitely not assume that about both them and our families as a whole. So very, very tailored interventions, but also that are based on individual needs and most importantly the wishes of both the family members with Rett syndrome where appropriate, and of course parents, carers and families as well. And I suppose that the reason for mentioning that as well though is that it should always be a collaborative process, but obviously there may be sort of you know, some families who are less keen on considering pharmacological interventions, and our role is to always provide enough of the most helpful information, but that experience should be different from feeling sort of pressured or forced in any shape, size or way or form at all. Having said that, what I will say though is that for me it's interesting as a clinical psychologist who's just sort of primarily worked in this field, I suppose what I've always had a sense of is that, you know, the continuing impact, significant impact of stigma and conscious and unconscious biases in terms of mental health symptoms and difficulties. And what I will own as well, and I think this is why, I mean, even within my professional group, it's probably no surprise to you, I think I'm viewed as quite strange sometimes, but I'm happy, I'll take being a bit strange if it works for our families, is that actually, you know, that even professional colleagues can inadvertently unconsciously project their own personal biases into their communication and work with our families and as well. So for me, I suppose sometimes when I'm sort of with colleagues as well and with families as well, it's like we wouldn't necessarily we may or may not show the same level of caution when, for example, a medical colleague recommends, you know, if my GP sort of recommended something for my migraines, you know, I probably would think about it a certain way because it relates to a very obvious physical health condition. If at the same moment my GP said to me, Ruksana, you're a bit more anxious than usual, what do you think? Do you think if I suggested something to help you? I think just by definition of our experiences, we tend to think about those sorts of things from particularly pharmacological interventions slightly differently. But what's really important is to also own that actually that can be very, very present within professional disciplines as well. So just really to hold that in mind as well. But bottom line, it's always about us being led by our family members and parents and carers as well. So then just really to think more specifically about what we can do in terms of pharmacological treatment options for anxiety, for low mood, for a range of sort of mental health symptoms when they arise in the context of Rett syndrome. What I would say is that we hear this a lot from you all, is that actually often you are providing, as parents and family members, you are providing professionals with expertise around Rett syndrome. So if you think that how much you're ending up doing that in a range of medical specialties, for example, the reality is that the majority of sort of mental health services are actually even much, much further behind. And so the level of expertise or sort of, you know, how well our family members fit in current service models, the reality is I think there's still quite a lot of work to be done. And actually from our point of view, that's part of the reason over many years as well in terms of wanting to sort of establish the Rett Centre as well, for us to be able to deliver that level of expertise and holistic care in one place for our family members. From a pharmacological point of view, what I would say is that what Professor Santosh and the medical doctors in our team bring is quite different. from most other services. And the reason I put the sort of contribution of SIPRD in addition to what we're doing in the Rett Centre is because the model that we're using in the Rett Centre, for example, from a pharmacological point of view, and the Professor Santosh, the doctors use around medicine, is very, very different to perhaps what might be received. Things have moved forward, but potentially what could be received in a community mental health team, a CAMS team, for example. So the model is actually a lot of very, very specific expertise around different sort of medications that may target symptoms. And the model is to around minimum effective dosing. So to use the lowest doses possible with the least side effects and negative consequences as possible, but most optimum results in terms of symptoms. But again, I never want to cross a line that I shouldn't, but that's sort of Professor Santosh and the doctors in our team. But I think it's a very, very specific model, and it's very integrated then with our sort of psychology model and non-pharmacological interventions that we recommend and often provide within the service as well. From a psychological point of view, I've touched on some aspects already. I suppose for me, it is that and often our family members, often there's very, very good teams around, and it can be sort of multi-agency teams. So a lot of our sort of family members, young people, you know, are in very, very good educational environments and contexts, in care contexts, accessing different environments where lots of very, very helpful environmental strategies and behavioural strategies are being implemented in a continuing fashion to help with anxiety, help with all sorts of sort of emotional difficulties or presentations that can arise. What that usually requires in the context of Rett syndrome is quite a high level of skill in terms of sort of being able to evaluate what behaviours mean and what changes in behaviours mean. And also in our team, I suppose what we would add on is incorporating the biophysiological data into those observations as well. We often strongly recommend and consult around, but also we're aware that a lot of this expertise often sits with our multidisciplinary colleagues. So from a sensory-based intervention point of view, hopefully our family members will have access to OTs, to OT intervention plans, but actually sensory-based interventions in terms of how they can contribute to supporting and targeting anxiety symptoms are highly effective. So those are some things that we often sort of either flag or consult around. But like I said, obviously also always ensuring that we're respecting local expertise in the teams around our family members as well. In terms of modified psychological interventions, we know that actually there, you know, a lot of our young family members can have communication difficulties, but can function well cognitively. So also I think sometimes there's always scope to consider direct psychological intervention where appropriate, but obviously it has to be highly modified and to take into account whichever communication system is most optimal to then deliver that type of intervention. Psychoeducation for parents and modified parenting intervention. Just to be clear with parenting intervention, what I mean by that, what we're very clear about with our parents and families as well, is that the majority of established evidence-based parenting interventions won't meet the needs of our family members with Rett syndrome necessarily. So these are quite sort of different and highly modified. And obviously sort of parental and family support where appropriate. But I suppose what we're also very conscious aware of is the significant role of both Reverse Rett and Rett UK in relation to the provision of parental and family support and intervention as well. Other aspects of psychological intervention that contributes to the holistic interventions and care plans is psychoeducation for professionals and teams around the person and family member with Rett syndrome. And for me, over many, many years, I just think this can be so effective, in terms of how our family members are being understood across contexts. And actually, sometimes that shared understanding and shared formulation can be all the intervention that is required. But often that is the foundation upon which we can advise around appropriate strategies as well. So it's a really, really important part of intervention. We try to do as much as we can in terms of training of teams around family members with Rett syndrome and a range of conditions. And also, I suppose, working with systems and across agencies. And for us, it's really, like I've highlighted already, it's sharing the most important information about our family members and facilitating information sharing on behalf of our parents, carers and families as well. And I suppose quite that sort of specific role around advocacy, but obviously not obviously not sort of wanting to present of yourselves as colleagues within Reverse Rett and Rett UK, but just in terms of how we are communicating the clinical information and recommendations that are within the care plan that sits within our service as well. I suppose I just wanted to sort of also highlight as well, and I know we had done a previous session, but just to emphasize again that in terms of sort of our family members with Rett syndrome, they are within sort of our families. So the importance in terms of parents, carers and family members' needs being reviewed, considered at regular intervals, and where appropriate signposting or to encourage support is accessed. Again, I suppose what I would say from my point of view, and I think both your organisations do this very, very well, is that it does require tailoring. And it does require all of the skills that you have within your organisations of building positive, trusting relationships with families and family members. I suppose the other thing I wanted to say, and I hear this question a lot from parents sometimes as well, it's okay for me to sort of talk about anxiety and low mood and these difficulties as well. This isn't us saying that any of our parents or carers have missed something, because I think the reality of what we're saying as well is that in the context of Rett syndrome, but most, a whole host of other conditions as well, these symptoms present quite atypically at times as well. But also, so one thing is where is that expertise in your professional network? That's the sort of question that I pose sometimes around sort of supporting yourselves with these things. And I suppose the other aspect of it as well is that as parents and family members, you are grappling with so many different aspects of your family members' sort of needs on a moment by moment, day-to-day basis. And I think, again, just to sort of come full circle, I think that's where we hope our centre can contribute positively alongside your organisations as well, in terms of just being able to do that continuing monitoring. And we were talking about health tracker codes and things like that as well. Those are all the systems that we utilise across all of these areas of need in terms of symptoms of anxiety, to continually proactively monitor, and both also sort of monitor and assess and intervene as required as we work with our families and through the care that we provide as well. Just then to sort of widen the system a little bit. I know that you guys probably have heard me say this too much, but I think I can't say it enough really, and it's on behalf of our family members with Rett syndrome and all of our families really in your organisations. I think there are wider system-wide implications as well, the continued need for the dissemination of information. I think for me, you know, Reverse Rett UK, your role, but our role as a centre and individual and collectively as professionals to continue to empower both our family members, but families as a whole, in terms of so how you are both sort of accessing and receiving support and care. I think there probably are continuing training needs across disciplines and services. But also, like I said, there's huge strengths as well, particularly in terms of sort of all of the contribution in terms of Reverse Rett and Rett UK. So we're very happy to be able to sort of work alongside you all in order to sort of continue to contribute positively in these areas and others, both from a clinical point of view and, as you're all aware, from a research point of view, in terms of continuing developments for Rett syndrome as well. Thank you.
Well, thank you very much, Ruksana. I think that was really interesting presentation. And I have to say, I wrote down a few questions, but you kind of answered my questions as I was going along. But there is a question in the chat that we have here. So you mentioned that interventions need to be modified. Can you give specific examples of the sorts of modifications that are required, for example, with medication and psychological interventions?
Yeah, absolutely. So in terms of, again, if I sort of just very briefly touch on the medication, both from a point of which medication sort of choices or recommendations are made, the overall model is that it's not, and this isn't just for Rett syndrome, so it's not sort of targeting medicines to a disorder. So that there's been a sort of a long history of a sort of attempting those things. For example, you know, is this the treatment for autism, or is this the treatment for Rett syndrome? So the model that we have in the team is that we look at the symptoms that are most prevalent and impairing at any point in time, and then Professor Santosh will bring his expertise and the doctors around the sort of pharmacological agents that are likely to most optimally target those. And then for me, also around the sort of the medication implementation and monitoring, there is psychology around, because obviously there understandably will be concern and anxiety while treatments are being implemented as well. So we do both in terms of, but very, very tailored to each family. And further then, I suppose, in terms of sort of modifications from a psychology point of view, I don't want to sound as if I'm being wishy-washy, but the reason is that because we tailor at such a high level, so for me, everything comes into account in terms of behavioural strategies. You know, what's that young person's or what's their personality like? What do they enjoy? What are the strengths? What are the strategies that work already? It's not about me being arrogant as a psychologist and wanting to sort of just come in with my strategies. It's also working sort of almost as co-therapists with our parents and family members as well. And then looking at what the data is showing from a behavioural point of view. So sometimes I might tailor more and recommend more sensory, environmental changes and strategies. Sometimes we may recommend more sort of cognitive strategies. Behavioral strategies, there are more limitations. And I know, Rachel, you and I have discussed this sometimes as well. If you think about anxiety generally and breathing exercises, and you can't necessarily use those at all in the same way within Rett syndrome. But for me, that's where, from a behavioural point of view, the sensory strategies, and particularly sensory strategies, can be much, much more effective at very heightened levels of anxiety or distress as well. But overall, you know, to be very, very sort of individualized and tailored. And then also what we do within that as well is that we would implement potentially, let's say, for a week or two, but monitor response to strategies as well. because if there are strategies that aren't working optimally, then we would then sort of change those strategies as well. So it's quite a dynamic process as well. I'm hoping that sort of answers the question.
Don't know if Gail's there. Are you there, Gail, to say whether that answers your question?
And you can say no as well.
I'm not sure if she's there. I mean, I had a similar question to the part where you were talking about modifying. You said direct psychological intervention, and I suppose one of the things that you think about for a verbal, fairly healthy let's say mainstream child, your first port of call would quite often be a counsellor. You know, if my teenage son has some anxiety, the first place he's going to get sent is probably a counsellor, psychologist, someone you can chat to, which is obviously not something that my daughter, I don't know of any other person's daughter who's been offered that. And I know it's something that I've talked about with Rachel in a personal circumstance, being offered counselling for something else, but not for this devastating condition that you're living with every day. You know, is there anything that, I don't really know what my question is, but is there any way in which direct psychological intervention can be modified in terms of counselling, or a way that, because I think a lot of the problems I see is just frustration, which is completely understandable. And, you know.
And again, I think, I mean, it's a really, really good question. And I think the answer to that is often determined by a couple of things. Firstly, in terms of levels of cognitive functioning. And then secondly, in terms of communication systems. So what I usually say is that communication difficulties in the presence of cognitive strengths should not exclude attempts to work directly with young people, adults with Rett syndrome. But obviously that would require a lot of significant modification. First of all, it has to be decided and evaluated if it is required and would add value, because also that's our sort of ethos throughout. We never it's never about doing things for the sake of it. But if it's required, there's a need and there's a potential to add value. So not necessarily just in Rett syndrome, but for example, acquired brain injury, for example, in a range of conditions where the communication, the external presentation is non-verbal, but cognitive capacity and skills you know, are either remain or at a certain level, you can actually deliver sort of therapeutic intervention through, but it has to be modified in terms of the communication. So, you know, I've used a lot of assistive technology over the years. I've worked with young people who are catatonic, so can't speak or move, but they can press yes or no on a computer. And I suppose, again, it's not to sort of sing our praises, but I think there's something about sort of, you know, my method always has been, if there's a will, there's a way. And again, only within the sort of overall caveat of if it will help and can alleviate anxiety, can improve well-being. But again, you know, in our acquired brain injury group, we have a lot of young people who are trapped in, you know, different terms are used for it, but do have access to different communication systems. So alongside all of their other therapies, we would always want to evaluate and or make recommendations around a version of talking therapy, psychological intervention as well.
It's just
really interesting. Sorry, Beth.
Go.
Well, I just had prompted some thoughts in me, and I hope you have time to continue to talk about it for a few minutes, Ruksana. But it prompts lots of thoughts in me. But the first one is thinking back to what Beth was saying, you know, when I had told her about the fact that my daughter had been sort of offered genetic counselling because she has another genetic disorder, and the other two children who have the same parents as Amber had a lot of counselling, and she had a little bit. And we did it in this kind of modified way where they brought in a learning disability nurse, and I was there, and the counsellor was very uncomfortable, the genetic counsellor, but she asked Amber questions and then kind of looked at us, and then we maybe simplified what she was saying a little bit, or just reassured Amber, and then got Amber's answers out of her in a very informal way without having a proper communication system. So she has, you know, obviously she's quite good with very good, I should say, with expressions and yes and no and so on, but no one else would probably say it was a formal communication system. But we kind of got her consent for the blood test, and the learning disability nurse was happy enough with that. But having experienced a lot of counselling myself, I think there's something to the fact of, even if someone hasn't got a standard communication system, of just being seen and heard by someone external that's not in your family, and they are acknowledging that you have feelings and what, you know. The other thing is, just because she hasn't got an external communication system, I know I'm telling everybody this when we all know it already, doesn't mean that she doesn't have her own thoughts and things. And I've had a few counseling periods where I've had like hypnosis and things like that. So is there any, is that the kind of thing you might use with people who have the brain injuries? Or
yeah, no, I mean, we sort of sit very much within sort of the evidence-based models that are available. So actually, in terms of behavioural intervention, modified CBT, and it's interesting because CBT is cognitive behavioural therapy. And for me as well, it's like the cognitive bit, the assumption is, and the majority of CBT is pitched at sort of typical levels of cognitive functioning. For me as a psychologist who's always worked with a whole spectrum and range of abilities, strengths and abilities and functioning, Rachel, my thought is the same as you, is that as a psychologist, it's my job to find out what that young person or adult, at whatever level of functioning, at whatever point that I sort of access them, what is their level of understanding, and how can they be part, as much as part of the process throughout. So it's really interesting, and often the majority of the work that I've done in my career is often in the absence of those established communication systems, because what we know at certain levels of communication difficulties, those systems are absent often. So yeah, our model is very much the same. And also because if you think about it, for me, I suppose what I try and sort of remind myself is that, you know, if it was me or my child or, you know, the young person, you know, of course, you know, there's all these people around them who aren't familiar. Yes, the parents are there and family members are there. They're having things that are happening inside them or in their mind physically. So anything we can do to help them understand what is happening to them, whichever, even if it's at the most basic level or simple or straightforward level, it should always potentially be our starting place, because that in itself is incredibly therapeutic, but actually really, really powerful in terms of alleviating anxiety. So for me, it's a good question as well. So I sort of think as a psychologist, I intervene as soon as I have contact with someone, if that makes sense, obviously always with their consent and as well. But this is where you have to do things so differently. So it's not about me waiting to see someone over 6 sessions and it has to be this way, and then we might do this or we might do that. No, you have to almost sort of quite dynamically and spontaneously use skills alongside sort of parents and carers, that in any moment you are acting to alleviate anxiety and improve well-being. And for me, that can be in an appointment, it can be, you know, in any sort of context or environment as well.
And that's really brilliant. And then just thinking in terms of, because, you know, one of the things you were saying is that a number of these drugs, particularly the AEDs, are, cause emotional disruption already. So there might be people for whom it's not realistic to add in another medication either, or it just doesn't feel right when it's the medication that's kind of causing the issue. And then we talked about how in Rett syndrome, people can't regulate their breathing and they can't follow instructions. So you can't help them to calm their, what did you call it, unrestrained vagal tone in that way, like we can for everyone else. So one thing I was thinking about was, there's kind of, I don't know if this is evidence-based or not, but the people listen to, is it binaural beats and things like that to try and calm their,
yeah, definitely.
Is that something that you ever do with people who aren't able to?
No, absolutely. And I think, Rachel, what you're touching on is what I was referring to in terms of sensory intervention. So there are lots and lots of different models, and it sits within different expertise, primarily often OT, but actually there are developing models as well. The other thing I sort of think with all of our, this is the individualizing, is that a lot of certain things work for certain young people and adults and families. So actually that's where it's really important to get quite creative and try different things as well. So absolutely sensory strategies. And I think that's what I meant. Sensory strategies often are the go-to for all of the reasons that you've described, whether it's related to medicine or other behavioral strategies aren't the right ones to go for at all. But also environmental strategies are very, very important. So actually, if we have hit our limit in terms of what we can do from a pharmacological point of view and a psychological point of view, from an internal point of view, we can absolutely think of lots and lots of things from an environmental point of view, and actually in quite a dynamic fashion. So actually it could be that actually when anxiety is higher and we all of those strategies are in place, we can reduce demands environmentally. We can reduce sensory stimuli environmentally, externally as well.
Can you say what those things are? Because to me, when somebody says sensory, I immediately go, oh gosh, that means they think Amber doesn't understand anything, so they want to put her in
no, absolutely not. No, absolutely not. So it's anything tactile, sound, touch, smell, all of the senses. And what's really interesting is that it's interesting you said that, Rachel, because actually for me, what I find in actually people who don't have the same communication difficulties and actually are cognitively very able, in the context of heightened anxiety, even in that group, these are the only strategies that often are the most effective. So it's really interesting that actually from your point of view, your worry was, oh, people assuming that Amber's not getting it or that they're sort of dumbing down for her. Actually, it's almost the complete opposite. If you understand it correctly and are implementing it in an appropriate fashion as well. So yeah, all of those things. But in terms of reducing demands, to give examples for that, it's at every level. It could be, one extreme, it's that actually are breaks needed from stimulation, from education, from activities. And again, we can worry when we're thinking about implementing those things like that as well, is that actually if we decrease or modify, will that mean that our family member won't be able to get back to where we want them to? But the reality is that with support and sort of quite careful manipulation of those sorts of strategies, you can actually alleviate anxiety and symptoms and re-optimize relatively quickly and prevent further decompensation. But again, it's being able to sort of work together and often work across agencies and across professional disciplines to sort of think about these things as well.
That's really helpful. I didn't mean to sound kind of dismissive about the ball pit, but from an early age, swing, ball pit and all this, how is that going to help anything? The other point that I'd like to make at this point is, and it's just a comment really, I think that, and I've said this to you before, Ruksana, and so I'm preaching to the converted, but especially as we move into a time where there's more and more emerging treatments for Rett syndrome, and some of them could be potentially life-changing but also risky. we have to start including people with Rett syndrome in the conversation a bit more about what's going to happen and whether it's worth, risk benefit analysis. And there will be people that don't have a standard communication system, but will need psychological support with those processes, and just at least so that they have agency in the decision or in what's happening to them. Because this is something we talked about a lot when we had the scoliosis panel as well. People have these big operations that have such a drastic effect on them, but nobody really discusses it with them. So
Absolutely.
I think that's part of, I was going to ask something. I mean, it's not similar, but it's the same kind of idea of, in light of that, and in light of not just treatments emerging, but all these things that the girls often and boys often go through, like surgery, the very big life things, involving them in that conversation. And I was wondering, Ruksana, if you see any general move towards that happening more, because I know that when I feel like I've just hijacked that question. Actually, I'll come back to my question. Go back to Rachel's question. I've hijacked it.
Can I link the two? Can I link the two?
Yeah, I'll follow up in a minute.
No worries. So Rachel, I think what you're saying is beyond imperative. And actually we need to be as proactive and forward thinking and planning as we can together, in terms of thinking both from how, but also around a lot of these things. In terms of our team and in service, we have established protocols. But the other thing I would say as well is that we would never say that we're the only team, or only, I'm the only psychologist who does this, not at all. But often we end up being asked to top up or join because we have positive and very strong sort of therapeutic relationships with our young people, adults and family members as well, but we can add. But there are sort of protocols that we have developed over time to think about these things as importantly and explicitly as it should be, but always alongside sort of the young person, adult and family, most importantly as well. And I think then, Beth, your question, I suppose then I've sort of answered, is that there's a general move and understanding that this is a very, very important part of the work, and essential. I suppose, again, not to put a downer on that, I suppose all of these aspects, not just this, but in a continuing fashion, will be impacted by all of the usual sort of issues around resources out there that we're all experiencing, which for me just sort of, I suppose it saddens me, because I think COVID has only impacted further. But that doesn't mean that we can't all do something together and think about these things in a helpful way. And I think, again, for me, that's where particularly your organisations are so important, in terms of both complementing, but often actually provision of support in the absence, when it's not sort of available as standard as it should be as part of sort of typical services. But very...
I guess, I mean, I know you're saying you're not the only team, but
in my experience,
you're certainly, I know that when the first time we came to see you, that was the first time anyone had so much as mentioned Hannah's mental well-being, that side of things, and I think in that context, much as it often is in clinical terms as well, it's all just been, but she has Rett syndrome, so it's just part of that. It's just part of that. Let's not bother trying to do anything about it. And really, when we came to see your team, that was the first time anyone even mentioned anxiety or anything to do with her well-being. And And since then, it's something that I've raised at school, for example, every time we speak to them. But what about this? What about, what about her mental well-being? And I think, as you touched on earlier, there's a tendency that, well, she's smiley and she smiles at school. She's happy. So she's fine.
Yeah.
And that's very much the kind of blanket, and even, close family members will say, oh, was she so happy? And you go, well, if you look at the evidence, she can't be happy all the time. She's a 14-year-old girl for a start,
yeah.
but she's also a 14-year-old girl who is trapped inside her own body.
Yeah.
Anyone would have mental health issues with that, and anxiety and low mood and worries. So I think, I was wondering if you really have seen a kind of shift in, or if indeed other parents who are listening have seen a shift in, is that actually finally being addressed a little bit better, a little bit even just acknowledged as something that we ought to be considering. For the first time yesterday, we had Hannah's annual review yesterday. For the first time, they spoke about a well-being, what did they call it? A well-being record, or they are now keeping track of well-being and recording things in relation to children's mood and feelings and their well-being in that sense, instead of it all being about their medical situation.
So in terms of sort of not just Rett, but in terms of our work with rare diseases, so again, it just speaks to our history a little bit. I won't go on about this too long, but because we set up the service originally at Great Ormond Street, so actually our direct link to children, adolescents and families with rare conditions. So actually what we've done over the years is that with specific groups, whether that's Rett syndrome, MPS, septo-optic dysplasia. So there's a number of rare conditions where our team and service, we have the largest cohorts in the UK. So all of those professionals and teams are very aware of our service and do refer for the expertise, both pharmacological, non-pharmacological, around mental health difficulties. So I suppose what I would, and I think even outside of our team, again, within the rare diseases charities arena and groups as well, there's been a lot, but it's the parents and families' voices that have driven this, and the young people, in terms of highlighting these areas of need. Because one thing as well, in traditional services around rare conditions, what happens is that you, in certain conditions, you will have genetic counselling, but also in terms of the psychology models within those services are very different to what we've established over time in our service. And often it will be around assessment of functioning, for example, or cognitive functioning, or very specific roles, which are absolutely required and invaluable as well. But what we've highlighted over the years as well is that actually for the psychological need, mental health need of both the person experiencing the rare disease and their family is also as significant and impacts quality of life. And also something about timing. Lots of our young people are going through very dynamic changes, transitions vary, but our families as well, the psychological journeys that you're on, being offered it at a certain point, and either you accept or you don't. But actually the reality is the journeys that we're all on and you're on, that may not necessarily be the most ideal time. So again, what we've got the luxury of doing, because we've developed the model in our service, is that we don't put a time frame necessarily on when we would do that work or offer that support. For us, it's very much a continuing process. But yeah, I think that, but resources is the key factor, I think, around a lot of these issues, sadly, as well. The need is there, and the resources, but hopefully we can keep sort of...
Ruksana, I agree with you there. But the only issue is if it's something that's ordinarily provided to children that are healthy, or young people that are healthy, or adults that are healthy, then it should also be provided. And the excuse of it you know, oh, it's difficult because we don't know what they understand. You can talk to someone who doesn't understand. You can like
yeah. And Rachel, you might, I don't want you to trigger me because I'm hoping I've come across reasonably well this morning. But again, in terms of rights and you know, dignity, rights, access, equality of access, and I'll stop there because I might then start.
But what you've been saying this morning has emboldened us to be able to make the argument that it's discriminatory if people don't try and find workarounds.
As it should, absolutely.
That's something that I'm grateful for rather than it coming across like I'm going, but you know, equality and all that. So, but we've taken up so much of your time and it's been brilliant. And I think we've thoroughly excavated a few of these areas, which has been really helpful practically. And I just also feel supported by the things that you've said in terms of trying to seek out this kind of help, certainly for Amber moving forward and for everybody who has Rett syndrome. And I'd just like to add as well, if people are not currently being monitored by the SIP Rett Centre, they can just get in touch with us directly and we will help them with that, or they can email and we can send out the email, the direct contact email for people to sign up for that afterwards. But I think we should wrap up the session there. Thank you so much for taking the time to be with us and for giving us this extra time to have further discussion and answer these questions. Beth, there are more sessions coming up in the next couple of weeks, aren't there, around another area which everyone will need emotional and psychological and anxiety reducing support in dealing with, which is transition.
Yeah,
those are joint sessions again with Rett UK. So Beth, go ahead and give us the details, will you please?
Yeah, I think they tie in and follow on from today's session really well. Actually, we've mentioned transition a few times. So next Thursday, the 21st at 11 o'clock, we have a parent panel talking about general experience of transition. You know, the challenges, the services, the support that's available, and the different experiences and outcomes they've had. And then the following Thursday on the 28th, also at 11, we have a parent panel talking about the funding aspects of transition to adulthood. So how do you get funding for support and care? What fights do you have to be ready to fight? And obviously answering questions as well. So I will put the links to those into the email that will come out after this session, but do pass that on as well to anyone that you know who's got a teenager and looking forward to this exciting time of life. But I think everything we've spoken about today will be very relevant to those sessions as well. Thank you, Ruksana.
Thank you so much.
Session.
No, as always, thank you for having me.
Yeah, no, thank you very much for being here, and hopefully everyone will have a happy weekend after this. Happy weekend, everyone.
Absolutely.
Thank you very much.
Thank you so much, everybody.
Thank you to everyone for attending.
Take
Bye.
care. Take care. Bye.